I'm introducing Dr. Mruthyunjaya and Dr. Hamid, and they're going to be talking about retinopathy and side effects of treatment and side effects of metastatic treatment.
Thank you for again having us here. And the best part of the morning just happened, Dr. McCannel. Now we're going to learn something. So we're going to kind of combine, I think this is going to work well. We're going to combine two elements of treatment, which is not only the successes that we can see, but also what to expect as a patient that can happen along the way. So not all roads are smooth. Sometimes they can be a little bumpy. Sometimes those bumps can be smoothed out as we go. But I think, again, knowledge of what might be expected is going to be important in your journey as well. So what we'll talk about first is what happens to the eye, and then Dr. Hamid's going to talk about what may happen to everything else but the eye if there's treatments that are given through the body. So again, my disclosures. And Dr. McCannell is going to offer her perspective too in one of the very innovative surgical techniques that are being used to try to minimize some of the side effects. So as we all know in this audience, when we're talking about how we approach treatments and priorities for patients with uveal melanoma, our first priority is to preserve the health and well-being of our patients head to toe. The second priority is to save the eyes when we can, when it's safe. And the third, and it's in really small print, is to save or enhance the vision. And it's not that vision isn't important. It's a very important part of what we do in our quality of life and our ability to interact in our environment. But sometimes we have to put higher weight and greater priority on different elements. We know that there are two main forms of treatment of uveal melanoma. There's some others that can be used as well. But the first is enucleation, or removal of the eye. And the second is radiation therapy. And there's two flavors of radiation that are used typically. One is external radiation, which is either with proton beam therapy, gamma knife, or cyber knife. So basically, radiation sitting in a big device that kind of flows through the air and gets targeted into your eye. The second is called plaque brachytherapy, in which radiation is placed directly onto the eye itself, and that allows for directed treatment into the eye to treat the tumor. The fundamental concept is that the radiation needs to be directed towards the tumor itself, and that radiation kills rapidly dividing cells, which is what cancer is. Rapidly dividing cells soaks up the radiation, and it kills those cells preferentially versus kind of neighboring or normal cells to a lesser degree. And there's different ways that it can be delivered. So this is a patient undergoing state-of-the-art proton beam therapy. So this is where the radiation is kind of taken from an outside source, made into a fine column, and it's placed through the eyelids, through the eye, and into the back of the eye where the melanoma is situated. The patient is placed in kind of a device to hold their head and their eye in place, and very careful planning is done with a lot of big computers in order to get the tumor treated directly. You can see on the right there are these circles on this picture of the eye. These are what the radiation oncologists help to decide are the adequate doses that are being used, and to help us figure out what other tissues might be involved in the treatment, meaning that there are bystanders to the actual treatment itself that may also be affected. So this is kind of the planning that's done for proton beam therapy. The other type of treatment that many of you may have had is what we call plaque brachytherapy. So a plaque is just basically like a thing that we stick. Brachytherapy means taking radiation, putting it right close to the source that it needs to target. So bringing the radiation to the tumor is what we call brachytherapy. This is an example of a disc that's placed on the eye. So it's made out of gold, like real gold. And within the gold itself, there are these little seeds, like grains of rice, that are charged radiation particles. The reason why we use gold as a cover is that the gold prevents the radiation from going through it. So if this gold is placed on the surface of the eye, and between the eye and the gold is the radiation seeds, the radiation can only go into the eye. It doesn't go out. So that's why you don't lose your hair, you don't have brain damage, and you don't damage the other eye, nor do you get sick in other parts of the body, unlike other patients that you may know that have had radiation for other types of cancers, directed focal therapy. So this is an example of what we're talking about. This little black thing in the eye, we'll call that the melanoma. At the time of surgery, your surgeon places this disc on the outside of the eye, and it's sutured into place. And then over the course of several days, 4, 5, 6 days, depending on where you may have your treatment, there's this radiation that's delivered into the eye, into the tumor, but it's not going everywhere else. It's just going into the eye itself. And over time, we see the clinical shrinkage of the tumor in a highly effective way. The most common isotope that's used, or radiation sources used in the United States, is iodine, so iodine 125. If someone has thyroid cancer, they get a type of iodine that's called iodine 131. So it's a different type of iodine, but it's radiation that's delivered with these specific qualities or characteristics. When we go to the operating room, it comes in this big locked metal box. Very fancy. We call it a pig. I don't know why it's called a pig. So, and when we open it, specifically designed to the patient is this gold plaque that is handed to the surgeon by the radiation oncologist and their team, and it's carefully monitored, and if you lose it, it becomes like a nuclear incident. NASA, I don't know what to do, but it's a big deal. We care for it very carefully, and it's highly regulated. So that's why it takes a real team in order to provide this therapy of not only radiation oncologists, ocular oncologists and surgeons, but also radiation physicists and radiation safety. So it's a big production that gets streamlined for each patient. So when we talk about the evidence, like why do we do this treatment, we have to go back to the 1980s and 1990s and this study called the Collaborative Ocular Melanoma Study, COMS, or COMS. It was a US government-funded study that incorporated multiple institutions across the United States that set upon looking at 3 different types of melanomas in a prospective, randomized, highly rigorous manner. They looked at small melanomas, medium-sized melanomas, and large-sized melanomas. And they looked at different types of treatments for each of those. The medium tumor trial, so that accounts for the majority of the melanomas that are seen clinically, looked to compare eye removal surgery, enucleation, with radiation plaque surgery. And they wanted to see, did it make a difference in overall survival of the patient? Meaning, did the type of treatment influence how your patients did in the long run? Short answer, no, it didn't. So they found that in the appropriate patient, whether you removed the eye or kept it in and treated with radiation, there was no survival benefit of one versus the other based on the size of the tumor. Now, we've talked now about the importance of survival, so preserving life, and we talked about you might be able to save the eye if you didn't have to remove it with radiation, but what about the last element, vision? So the COM study also gave us some information about that. It did tell us that plaque radiation had an excellent chance of being able to stop the tumor in its tracks. They said greater than 90%, and I think most centers now are clicking at greater than 95%. That's pretty darn good success rate for patients that have cancer. 95% chance of controlling your tumor, I take it. That's actually looking really good. However, what they found was that there was a side effect from this treatment. At about 3 years, they found that about 50% of patients lost a chunk of vision in that eye that had surgery. Now, how do you quantify that? And that's always hard, because I think people think different things. It didn't mean that everything went black. It didn't mean that it happened the next day. It meant that over time, about half of patients probably couldn't read the biggest headlines in a newspaper, right? Maybe more in the center, maybe their peripheral vision was good. Everything kind of taken together gives that aggregate answer. So there were a lot of factors that went into it. Was it how big the tumor was to begin with? Was it where it started in the center versus the corner of the eye? How much radiation was used? There were all of these factors that kind of came into it. But in aggregate, we know that radiation therapy can cause loss of vision. And why is that? Well, radiation, we know, kills the tumor, but there can also be collateral damage to the structures that help us to see. So here's an example of a patient with a melanoma. There are two key structures that we look at. One is the optic nerve, which takes the message from the eye to the brain. And the second arrow in the middle is called the fovea, which is the part of the eye that gives us our very central vision. So depending where your melanoma is or isn't, so in this case, that's where the melanoma is, we can't just treat the area of the melanoma. What we want to do is give a safety margin around it, because just because we think the melanoma is right here, there could be a tiny cell just, half a millimeter away from it, or 3/4 of a millimeter away from it. So instead, we make a safety margin around your tumor. So what we don't want to do is miss anything. We want to get it all if we need to. But in that, there can be some collateral damage. There can be radiation that's delivered at the same high dose that it's needed to kill the melanoma to those very critical vision structures like the optic nerve and the fovea. So radiation retinopathy is the condition that occurs in which there's damage to the retina because of the radiation. So you'll hear that term a lot, radiation retinopathy. So the truth is that it's not an overnight thing. It doesn't happen tomorrow after your radiation's done. It's a slow but progressive process. So the longer you are out after your radiation treatment, the more likely it is that it can develop or manifest in different ways. What are the numbers? So about 40% of patients will have this radiation retinopathy affecting the center of their vision at about 4 to 5 years after treatment. Okay? Not 100%, and it's not the day after, but over time. Vision changes, as we talked about half of patients by 3 years would have a significant loss of vision on average. Okay? So not everybody, but on average. So at the extreme, when we look at this, and this is a patient who was treated many years ago with a very high-risk tumor located very close to the center of their vision, we can see a lot of features clinically that we look for at every visit when our patients come back. We look to see if there's leakage of fluid. We look to see if there's leakage of cholesterols that are located within the blood vessels that leak out. If there's bleeding, if there's blockages to the blood vessels. We look to see if the eye is feeling so sick without having good blood flow that it starts to make new blood vessels, called neovascularization, which have an increased risk of bleeding and causing the eye pressure to go up. And then also, independent of the retina being affected, the optic nerve can be affected, and these can also be damages that can occur to the vision itself. There are risk factors. We might be able to predict who might develop this or who might not to some degree. Some have to do with the radiation itself. How much was used, what was the dose, how was it delivered, what type of radiation isotope was used. The second has to do with the tumor itself. So that's independent of the radiation, but what do I have? How big was my tumor? Where was it located? How close was it to these very critical structures? Was it very wide or very tall? That might influence factors that would lead to this risk. And finally, patient factors themselves. So do I have diabetes? Do I have high blood pressure? Do I have conditions that make my blood vessels not as strong to begin with? And then you're adding this radiation. So could that compound damage that would occur if someone didn't have those risk factors? What we've learned in looking at these patients is that we can take what we see in radiation retinopathy and try to apply what we know from other eye diseases that can cause similar problems. So one condition is diabetes in the eye. So in patients with diabetic retinopathy, they have often very similar findings to patients with radiation retinopathy. We can see abnormalities in their blood flow, in how blood vessels are created, and how blood vessels don't work as well. And a lot of those same features help us to pick treatments that we can use for our patients that have radiation retinopathy. And the second is a more technical scientific observation, is that there is a substance that our retina makes called VEGF, vascular endothelial growth factor, VEGF. So it's made not only by the melanoma itself, but also by the retina after it's been damaged by the radiation. And this substance kind of fills up inside the eye. And it causes leakage and sometimes bleeding because there's more of this substance than is normally around. So this comes to what can we actually do about it. So we kind of divide this into 3 phases. First is there a prevention phase? Is there something we can do to just not make this happen at all? Is there something we can do once it's there to treat it, so the treatment phase? And is there a way to even avoid this entire lecture and just cure it, before it even happens? So these are kind of the 3 main areas we'll talk about. But realistically, the goals that we have for our patients is to try to stop the retinopathy. If we can't do that, to try to delay it, so maybe it doesn't happen so immediately. And if we can't do that, maybe minimize its effect. So if we can't take it away, can we just make it not so impactful? So there's 3 ways that we can talk about how to prevent radiation retinopathy. One is improving the way that we deliver radiation. The second is reducing the dosing that we use to treat these tumors, so maybe less radiation is required. And the third is how do we adjust the surgery that we perform to reduce the exposure to radiation effects on the retina. So the first is, these days, the radiation that's provided by plaque radiation and proton beam is highly customized for each specific patient and their specific tumor. So what we take into account is the size of the tumor, the shape of the tumor, the location of the tumor within the eye. We look to make sure that the dose of radiation that's given is given in a very calculated way, so it's not more on this end and less on that end, unless you need it to be that way. And then there's a certain amount of time that that radiation has to be in the eye. So what we do is we examine our patients, we come up with the plan to use radiation, and then all of these factors are then put into a big computer system. So we take pictures of the eye, and we know how far these tumors are from the critical structures. Sometimes we get MRIs or CAT scans to model the shape of the eye, so we know exactly where the tumor is located. We'll do ultrasounds like we do in the clinic to kind of measure the size of the tumor. And then using sophisticated software that's used for planning radiation in other parts of the body, we can then plan the radiation specifically for the eye and get a prediction of what the dosing is going to be to some of these critical structures. We can actually do 3D reconstructions with some of these commercially available systems, so we know exactly at the time of surgery where we're placing the disc so that we can be accurate to a very high degree as to putting things exactly where they need to be. So the planning is a really critical component of trying to minimize risk of collateral damage. The second concept to prevent is maybe we can use doses that are less than what had been used before in order to get the same results and maybe less radiation that's exposed to the eye. So the collaborative ocular melanoma study said that we should treat these tumors to about 85 gray, which is like the temperature of the radiation that goes into the eye. That's given over a several-day period. So when I was at Duke, my radiation oncologist and we were looking to see if we could lower the dose that's been used. So we published some papers on this, and the bottom line is we found that we can reduce the dose of radiation that we give to these tumors by about 20%. And we still found that we could control the tumor, so we killed the cancer in the same percentage of patients. But we were able to reduce some of the radiation side effects by an equivalent amount, about 20% as well. So it doesn't stop it, it didn't miraculously change the course of time, but it did show that maybe there is a window that we haven't fully explored as to how little radiation we can use to safely treat and also minimize the side effects. So another approach is to try to adjust how we actually do the surgery in order to limit exposure to radiation. And a real pioneer in this is Dr. Tara McConnell, who's the director of the Ocular Oncology Service here at the Jules Stein's Eye Institute. And she's a vitreoretinal surgeon, which means that her expertise is not only in dealing with eye cancer, but also dealing with the retinal tissues itself. So I was hoping Dr. McCannel could share some of her experience on her revolutionary surgery. Yeah.
So we're good friends. Dr. Mruthyunjaya is an amazing doctor.
She's much smarter than I.
Anyone up there?
Fingers crossed. So as Dr. Mruthyunjaya mentioned, it's really important to keep looking at the way you do your treatments. And I think that some of the work that he's published at his previous institution and looking at new ways to treat patients is really imperative, because the way we treat melanomas with plaque brachytherapy really hasn't changed much over many decades. So I'm just going to tell you a bit about how this works, the silicone oil, and I won't repeat about the radiation retinopathy, but that's really the biggest problem when it comes to treating the eye. We can kill the tumor, but the radiation retinopathy is what gets the vision in many people. Dr. Mruthyunjaya is going to talk a little bit about some of the treatments for radiation retinopathy, and as you know, I'm using intravitreal drugs to inject into the eye to kind of prevent this. There isn't great evidence that it has a long-term benefit. So in the absence of good treatments for radiation retinopathy, we need to focus on a solution that will treat or reduce the radiation from the outset. How can we prevent this? So back a number of years ago, one of our clinical fellows, his name's Dr. Scott Oliver, who he directs ocular oncology at the University of Colorado now, he came up with this idea of testing what would happen if you put something in the eyeball during treatment, and could this reduce the radiation? And indeed we found that with various ways of modeling, with using cadaver eyes, we could reduce iodine 125 radiation by about 50 to 60%. We showed that in 2 years' time, that in patients, we actually had less radiation. And when we looked at fluorescein angiogram, when we looked at the circulation of the eye, we found that there was less progression of fluorescein angiographic severity. And a few years ago, we looked at only those patients that had the biggest tumors where the most radiation was going to be used. So you would expect that the more radiation you used, the more side effect there would be. And in this study, we found that vision was significantly better at up to 2 years afterwards. And most recently, we talked about iodine 125, but for the last couple of years at UCLA, we've switched to using palladium 103, which is considered more or less equivalent to iodine 125 in the brachytherapy world. And the reason we switched to this is because palladium 103 has a property that makes it much more attenuable compared to iodine 125. So theoretically, we should be reducing the radiation by about 80% compared to iodine 125 alone. So let me just show you a picture of how this may work. So when you treat the melanoma, you put the plaque on the eye, and this is an example when we were using iodine 125. The radiation, although it is focused at the tumor, there is extraneous rays that go to other tissue. So if you could fill the cavity of the eye, what we call the posterior segment or the vitreous, with a substance that will attenuate or block the radiation to some extent, then you can limit the rays of the radiation that go to the healthy tissue, and you still get treatment of the tumor. So this is sort of the principle of how the silicone oil works. And here's just a graph of our latest paper looking at doing this in large tumors, and we have good vision to the left and poor vision to the right. And the blue bars are people who had straight plaque alone, and the red bars are the people who had plaque plus the silicone oil. You can see that there's greater proportions of people with better vision, and when we look at poor vision outcomes, which is unfortunately something that can happen when we treat very big tumors, we can see that we have far fewer eyes with vision worse than 2200 or light perception or absolutely no vision in the eyes when we use the silicone oil. And I always talk about silicone oil when I talk to my colleagues at our meetings, and it has been very slow to adopt silicone oil at different centers. And I just want to pose some thoughts. Why isn't it the standard of care today? Well, I think, as we know, in the field of ocular oncology, we have a lot of very prominent people who have contributed significantly to the field, but they also are not interested in changing very much. So it's really hard to change the status quo. So people just like to do what they're used to doing, and I think it's a little bit of human nature, so we have to understand that. Many leaders in ocular oncology are not retina surgeons, so they wouldn't be comfortable going into the eye and taking out the stuff and putting in oil. Dr. Mruthyunjaya, however, is a retina surgeon, and a few of us out there are, but many are not. So this may be another cause. And then people are afraid of complications. And I think this is very important because we want to be very careful with everything we do for our patients and all of our treatments. We have to look at the risk-benefit. You know, what could happen if we do this additional procedure? And the first concern that came out of this was, yes, people get a cataract sooner than if we didn't use the silicone oil. It's possible to get a tear in the retina, which might need to be treated, and that probably wouldn't happen without using silicone oil. And it's possible that after surgery, people have a slightly higher risk of getting a retinal detachment. And we do see retinal detachment without silicone oil, but probably not as often. But the key thing to remember is that this list of possible complications all are treatable, whereas radiation retinopathy is not. So I think it's important to take everything in perspective when thinking about adopting new strategies. And I want to point out that some of the things we haven't seen is we have not seen tumor coming out of the eye where we make our openings to take the vitreous humor out. We have not, and we've looked at this now in over 400 patients that have had surgery at the time of plaque, that it does not increase the rate of metastatic spread. And that was one of the biggest concerns of the colleagues in our field, is that if you do so much to the eye, maybe you're causing increased risk to the patients. But we have data that this is not the case. We do not have an increase in local recurrence, which means the tumor coming back in the eye. And I've also been criticized over the years that if you do so much to the eye, you're basically you're gonna destroy the eye. It will basically sort of poop out. And this is what we call becoming tisical. And we have not seen eyes that have become tisical after too much surgery. That means the eye sort of loses its integrity and shrivels away. And we've also seen, we have not seen toxicity from the silicone oil when we remove it. And this is something that in the retina literature, there have been a few cases where people think if you leave the silicone oil in the eye, there may be some sort of curious, unexplainable vision loss just by using the oil, but we have not seen this in our patients. So just to summarize, at UCLA, if the melanoma is greater than 2 millimeters, and if the patient is phakic, which means if they have their natural lens, we usually recommend removing the lens and putting the intraocular lens in place, because not only will this eliminate the need for cataract surgery down the road, you can actually put a larger silicone oil bubble in the eye if there's a lens implant. We use plaque placement with ultrasound guidance in surgery, and we do a complete vitrectomy, and what that means is we take all the vitreous out. We just don't make a space and squirt oil in. We clean everything out, and because that lowers the rate of complications, and if a person does have a complication, it's much easier to treat if the whole eye has been handled in a very clean way. And what we also do is we remove the plaques in the office in most of the situations at UCLA, and once the retinal detachment associated with the melanoma has resolved, then we remove the silicone oil. And for most people, they notice a significant improvement in vision once the bubble's gone. And I want to emphasize that the complications that could happen are treatable in most situations. So I just want to show you an example. This is a case of a patient with a large melanoma. And so the melanoma, it looks really lumpy at the bottom, but the tumor itself is to your right, and the left bulge is really just a lot of retinal detachment with that. And this is a large tumor, so in many centers this patient would be offered enucleation as the first option or maybe as the only option. But the vision is very good here, 20/40. And so this patient underwent brachytherapy with the silicone oil bubble in place. And you can see that a month later, much of the retinal detachment has resolved. And the reason why eyes with melanomas get retinal detachment is because there's an actively leaking tumor. So it's leaking fluid and pushing the retina off. When the melanoma is killed, it no longer is able to leak fluid. And so the eye can actually pump out that fluid, and you can see the retinal detachment gone. And that line in the middle, that curvy line, is the silicone oil bubble, because now with the retina flat, the oil bubble moves around in the eye. And in this patient, about a year and a half later, this is with the oil bubble removed, his vision remains 20/40. Now, if you look at 10 years down the road, the vision may not be 20/40, but this person has really good vision for at least a few years after the surgery, and this may be very important for the individual. I just wanted to share that with you.
Strategies to try to prevent radiation retinopathy. Let's talk a little bit about, if you did develop radiation retinopathy, how could we try to treat it? So I think there are numerous customized treatment options that various doctors and investigators have looked at, and there's no one true gold standard way to do this. It might include laser treatment, it might include the use of steroid medications into the eye, or this class of medications that block that one substance called VEGF, so anti-VEGF therapies. So the VEGF inhibitors, or medicines that use to block VEGF, are now quite revolutionary in the treatment of eye diseases. There are three main ones that we talk about. One is called Avastin, the second is called Lucentis, and the third is called Eylea. And these are drugs that are made and formulated in very small quantities to be able to be given into the eye. How that's done is in the office, the eye is numbed up, and a needle is used to inject this medicine into the eyeball. Doesn't hurt, it doesn't change your vision one way or the other right afterwards. And it can either be given when the retinopathy develops, or in some cases, to try to give it even before the retinopathy shows up as a preventative measure. So there's been a lot of work that's been done to try to sort all of this out, and there are different strategies that have been used. So Dr. Finger in New York had been using repeated injections of the Avastin to try to treat patients that have radiation retinopathy. And basically what they found is that there was a reasonable chance of at least stabilizing the vision, and in some cases improving vision, but more importantly, not losing eyes to the complications of the radiation side effect. What we know is that when we are looking at, how does the literature guide us, treating active radiation disease in the eye, there are a lot of variable methods that people have used, and they've kind of been in different time intervals that they need to be given, different drugs have been used, and different dosages have been used. But at the end of the day, it seems that by treating with these medicines, there's an improvement in the structure within the eye. Vision is at least held to not being lost any further, and there is a decreased rate of some of the more involved complications from radiation treatment. There's other strategies that have been used to see if you can try to give this medication even before the patients develop the retinopathy. So at the time of treatment, they start getting injections and keep getting these injections, from day zero going forward to see if that makes a difference in their developing the retinopathy. And Ivana Kim in Boston did a study where giving injections at 2-month intervals over the course of 2 years had a decrease in the rate of developing radiation retinopathy compared to eyes that were compared to or controls. In another study done at the Wills Eye Hospital, they also found a similar trend towards better vision overall and decreased rate of retinopathy if given up front. So we know that by giving this treatment at the time that you have the radiation and then kind of the intervals afterwards, it is effective in reducing the rate of retinopathy, but we don't know how long that you need to give it for, what the dosage needs to be, and when do you stop. And the real question is, there are some patients that don't develop this complication and are then over-treating some folks by getting this all the time, or do you wait till they actually develop the disease and then try to treat it? Here's an example of a patient. So about 3.5 years after having treatment for radiation retinopathy, he's doing great. The vision's 20/20. Anatomically, things look pretty good. There's some early signs of retinopathy, but it's not causing any damage to the vision. Just 6 months later, this same patient comes back, and now things have changed. There's worsening of the retinopathy. Something happened where, just kind of got worse, like all of a sudden within a short period of time. The vision went down to about 20/40. He noticed that things were different. So we talked to him about options, and we started giving him these Avastin injections about once a month for 3 months. And he actually did quite well. He reversed that process. But now he's on chronic injections at frequent intervals going forward. And I'm not assuming that he's going to maintain 20/20 vision. But I'm trying to see at this point, since we've identified this problem, can we try to limit the loss of vision going forward? There are some trials that have been instituted and recently reported that have looked at giving patients very, very regular injections on a strict follow-up basis after the radiation therapy. One was by Dr. Amy Scheckler in Houston, and the second is by Dr. Tim Murray in Miami, where patients have been getting injections at set intervals nearly every month, kind of going forward. And what they found is that patients that start to develop radiation retinopathy and have these very frequent injections can show some very good anatomic results with preservation of vision and improvement in the anatomy as well. But I think Dr. Murray and Scheckler and Kim and Shields and Finger and others have been trying to work to find what is the ideal treatment. Do you give the treatment right when they've had the radiation and follow those patients with serial injections? When do you stop the treatments? Is it when 2 years go by, 3 years go by? But that's a lot of injections to get if you may or may not actually get the disease. Not everyone really needs these injections. So I think what's happened now is that there are some centers that follow a protocol that we give these injections at this interval to all of our patients, or at least offer it. Sometimes it's follow the patients closely. If they see a start to change, then you initiate treatment. And then some centers say, look, realistically, no matter what we do, there's no proven data that we're going to make a difference, so we're just going to watch it. And if you want it, you can have it, and you don't. I don't think any of those are wrong. What we still have to figure out is exactly what's right. And that gets to kind of the last step. Is there a way that we could cure this? And I think the short answer is right now, no. But is there better ways for us to understand what's going on? And Dr. McCannell's group and our group have been very interested in trying to figure out, are there ways that we can better predict if a patient is going to develop these complications? Can we try to identify, based on various factors of how we image the eye, that a patient is more likely to have this, and maybe those patients are the ones that need these injections more frequently? And then once we figure out these patterns, can we validate them based on the types of treatments that we use? And that leads us to the need for clinical trials. So I think that's going to be one of the things that we'll be hearing more about, is opportunities for patients that have had radiation treatment to be in clinical studies that may allow for testing out some of these hypotheses and see where we go. So what do I do for my patients at Stanford? So we try to customize the treatment planning. I don't use the silicone oil treatment, though the more I think of it, I really should, because Dr. McCannell's results are so good. But again, for various reasons, I think that there's different experiences with treatments, but I think they're all good. We try to minimize the dose that we use, and then I look at tumors that I think are high risk based on imaging and clinical features. I usually give an injection of the Avastin medicine at the time of surgery. And then we can offer interval treatments for high-risk patients at 4 to 6 month intervals based on their follow-up. And if a patient presents with active retinopathy, then we will engage or offer active treatment going forward. So in summary, radiation retinopathy probably will affect about 50% of patients that have had radiation at about 2 to 4 years after treatment. And that degree of involvement is going to be variable. It could be very mild, it could be moderate, it could be severe. And that's what we're still trying to figure out how to predict. Regular follow-ups with your ocular oncologist is critical because they'll be monitoring for these changes. So if they see something early, that may be an opportunity for a discussion for treatment. Treatments that are currently available may be helpful. They may not be curative, but I think that they can either try to stabilize the situation and hopefully improve if effective. And the importance is, of course, for more research as we go forward. So I think that's all we got. Thank you. Take questions.
Amazing talk.
That was great.
What do you do when you take out the oil? What do you put back in?
Well, that's a great question, yeah. So when you take the oil bubble out, you have to put something into the eye to keep its shape. So during surgery, we use balanced salt solution, which fills the eye, which is essentially like water, and then the eye's aqueous humor will replace that in about a month or so. So you just have aqueous in the eye.
The second is, this Avastin protocol off-label? Is it reimbursable?
Your experience?
Yeah, I mean, we use a lot of Avastin, and we actually use Eylea and Lucentis as well, because I think we would all agree that after a while, a person doesn't seem to respond to Avastin. A percentage of them seem to respond better to the more designer drugs. Often we give samples, and we do try to work with insurance companies to try to get it covered, but certainly Avastin is usually not an issue. So that's why I think Avastin, we offer that first.
So Avastin costs about $60 an injection for the drug, because you take a big bag of it, and then you make small little vials. The other medicines, Eylea and Lucentis, are specific for the eye, so they're about $2,500 a dose. Minimum, right? I buy this Costco.
That was a good oncology joke.
It's expensive, but it seems that they're probably all somewhat equally effective, but there are clearly cases that we would love to use some of the more expensive ones, but we can't always get them approved.
So, I go to see the two of you. A passion of the two of you. Can you talk a little bit more about the difference between Avastin and Eylea? Put the price to the side. Let's say they were the same price. What is the difference between them?
Well, I mean, they're molecularly structured a little bit different, and no one, I don't think we can we have all sorts of theories about one goes deeper into the membrane, but there are clearly people who actually respond better to Avastin. I mean, not even in ocular oncology, but in treating people with macular degeneration and diabetes. Some people just do better with Avastin than you would expect, because we have this thinking that the other ones are better, but it's not always the case. And I think just being open to, if people don't seem to respond, then we switch them. I think I still kind of do that, because I don't think we have, as Dr. Mruthyunjaya mentioned, we don't have a set protocol. Not everybody responds the same way, and I think in the beginning you have to sort of figure out what works best. And if it seems like it's drug X, then we will use that.
By the way, a quick comment, because I said $60. When you look at the bill that Stanford submit to my insurance, it's about $2,000.
Right. That's absolutely true. I get none of it, by the way. And I think that is, so if you got the designer drug, that bill would look like $12,000, right? So that's part of the system of cancer care, right? So drugs are expensive to make, and bills get transferred to the patient. Actual costs are different than what patients see, and that's a very legitimate, concern as you're getting injections every month in some cases. Then these are bills that scare the the heck out of us when we see them. So that's clear. I'll make one other point, that the challenge that we have is that this is a rare condition, and the companies have to want to put in time and money to invest to change the label that the government will approve these drugs for. So luckily this year we have 2 studies that have used, one's used Eylea, one has used Lucentis to treat this, and they've found positive results. The companies then have to say, okay, we're willing to do a larger study, we'll pay for it because ultimately we want to change the package insert that says this is approved for it. Because if that happens, then your insurance might say, fine, we'll let you use Eylea or Lucentis. But again, these are rare diseases and it's hard to do so. So again, we are trying to push that forward with these companies, but that'll still take time. Until then, we have the generic, which is still pretty fancy, which is Avastin, if nothing else.
Your guys, this is a different topic, but connected. Hearing both of you, all 3 of you actually talk this morning makes me think, you guys keep referencing that different doctors are working on different studies in different places. Is there like a central clearinghouse of ocular oncology where you guys all share this together? You mentioned your new therapy. Some people are more hesitant to do it. Is it something you just present at a conference, or is there like a place you guys all go so you can talk, so that, I mean, we've got 3 powerhouses in the room right now, and you guys are so amazing. We get to sit here and listen to you, but is there a way of disseminating all that to everybody, and how does that work?
I think that's a really good point, and I think that we think even since when we started, there's been a great shift to more collaborative efforts, and only through collaboration are we going to get the numbers that are going to be meaningful. A single center takes a lot longer to get data and bring it to people, and I know that Dr. Mruthyunjaya is very involved in a collaborative effort, and you and a group of other ocular oncologists looked at biopsy. We have other groups. I'm part of a group that's looking at everybody's results using the MLPA testing from IMPACT, and I think this is really the trend now, and I think maybe 15 years ago, it would be very individual centers would do their thing. But how we generally disseminate information is through publications, through meetings with our peers, and there are a few, in most big vitreoretinal societies and meetings, there is always a subsection of ocular oncology. So we all know each other, I think, pretty well across the country and world even. And I would say that there's much more communication now. I have people come and visit, spend a few days with me, and I show them stuff, and I think it's really important to not just see patients and plow ahead, but you have to figure out how to get that information to your colleagues so that they can think about it and be comfortable making changes so we can have progress. And I think actually things are really changing in that direction. Yes?
So I was diagnosed, I shared earlier, with ocular melanoma in 2001. And in 2009, I had a cataract surgery. And I had 20/20 vision until 2 years ago. And my eye's been hemorrhaging at the macula. I have a macular edema. And Dr. Murray's my doctor. And he's been very aggressive with treating me. I live at his office. I had a stroke in the right eye. My right eye is my good eye. So cancer eye, good eye. Had a stroke, the optic nerve's gone. I had that 2 years ago. So now I'm being treated both eyes with Avastin. For a while it was every week. Now 2 to 3 weeks. And then sometimes I have to have triacin, which is steroid in this eye. But I still have it's what he's told me is maintaining. It's not getting worse, but I have no central vision in this eye, and I have no peripheral in this eye. But together my brain is working as one, so I have one eye. So I'm kind of, I was hoping that there's a cure, I guess, for the macula, the hemorrhaging.
Well, I think, it's really important to look at all the things that are treatable. And if we've got something that can kind of limit progression, and it's really difficult too, because we talk about intervals and we talk about what drugs should we use, but I really think that everyone responds a little bit differently, and so you know, there may be, we have some people who get an injection every 3 months, you know, and the other thing I think I want to mention, because I explained this to patients before, is that before we had these intravitreal drugs, when I started, when we started, we inherited some patients who never had, we didn't have intravitreal injections. And we didn't see people, you know, slowly tank and lose all their vision. And you don't, Avastin shots and Lucentis shots, they're not, if you stop taking them, your eye is not going to go down the toilet. Your eye may make it a little worse, but you most likely plateau. So I think that you really have to look at the situation. Is it possible for a person to get injections, and also do they tolerate the injections? No, not everybody, for a lot of people it's not a walk in the park to get a shot. It's a huge ordeal. You take time off, and for some people the pain can kind of linger on for a while.
Yeah.
And not everybody has a painless experience. And most people can tolerate it very well, but there are so few people it's really tough. And if they're not noticing much benefit, and you know, you have to weigh all these things in deciding how to plan a person's injections if they're going to go that way. And also look at what is the visual benefit. You know, if the person's, are they stable with or without shots, then I know I probably wouldn't give them any.
Well, I know my swelling goes up if I don't, it gets worse if I've gone a month,
Yeah.
which I once did. I was like, well, and it got worse. So we had to put some steroid in to get that down. And then I just got steroid again. So,
Yes, can be
you
really
know,
hard to
I
manage.
don't want to lose my vision. So I'm grateful for what I have, you know, and I'm very grateful. So I'm you know, I don't want to mess with it, you know, so, but it's like a fine line, you know.
And I would echo that as well, and also point out that there are a lot of new drugs that are also coming out on the market as well. Some of these might have different mechanisms of acting or add another factor that might be protective or allow injections not to be as frequent as such. So again, these all would have to be tested and to see if it's effective, and then maybe they would be a better answer than what we have available in 2019. So there's a lot that's coming down the line. And you know, again, who knows? Things like stem cell technologies, other things are always a potential benefit. We just don't know what we don't know yet about what could help restore vision or change the course of what we do.
Thank you.
I was just going to comment that when I got diagnosed with cystoid macular edema, and you have these, I think they're called Amsler grids, where you look at it and everything's all, the lines aren't straight, that means you got cysts in your retina, you can't see. And so I was trying to get a little humor, and I'm like, okay, well, I don't mind distorted vision if it makes my butt look smaller when I look in the mirror. But that's not what happened, of course. So because of that, I'm doing the Avastin shots, and now maybe I have to get all that. So it's all relative, and it's an individual decision. Trying to put a little humor in, folks.
Yes. So I wanted to ask if you can talk more about the side effect of Avastin along the years. I don't know how many years you have experienced it, because every month and we don't know when it's going to stop. And also if you can talk about the laser treatment, about this option, and
Yeah, you know, when Avastin first came out for macular degeneration, that was 2005. And I have a handful of patients who are getting a shot for wet macular degeneration in the eye, keeping, I have this lady, I know her well, 20/25 vision every single month for now over 13, 14 years. And she just comes in and gets the shot, and yes, she's got, her disease is very suppressed. And her eye is doing well, she is doing well. And I think we always have to ask ourselves, what is the long-term side effect of constant shots in the eye? But I think we all have patients who have been treated now for wet macular degeneration for over a decade, getting monthly shots, and they seem to do great. We don't see retinal detachment, we don't see toxic things happening in the eye. There has been some concern, and some people talk about, what about the systemic absorption when the drug gets into the body? Because everything you put in your eyes is somewhere. hopefully not to a significant degree, but there has been some studies that suggest that maybe there's some risk of cardiovascular event. But when we looked at the studies more carefully, it looks like the patients are much older, because people who have age-related macular degeneration are mostly over 75, a much older population in general. So there's some associations with those people also, just by nature of age, get some of that. So I would say that I think that Avastin and Eylea and Lucentis are extremely safe. You compare it to steroids, which we know do all sorts of things like give people glaucoma and such. I find that these anti-VEGF drugs are one of the safest things that we have when we use them in the eye. And that's, we have to be cautious, but I think that our experience in other diseases shows that they are very safe. You can talk about the laser.
Yeah, sure. So, totally concur. So laser treatment has been used before we had these injections available to us. So we use laser in patients with diabetes that have diabetes in the eye. And that's what I was pointing out, that there are a lot of similarities between how radiation retinopathy looks and diabetic retinopathy looks. And laser has been very effective in controlling diabetic disease. So people have applied those same principles to using laser in eyes that have extensive bleeding, because the blood flow is not good in the eye and you get abnormal blood vessels. They've also applied it for leakage of fluid as well. I don't think there's an absolute yes or no to that. It's just that these days the injections have pushed laser further down the list in terms of options. Sometimes lasers are an option for patients that either really can't get the injections or are refractory to the injections or unable to travel for that, and then we can use the lasers. But I think just like things have different eras of fashion, right now the injections are kind of our first, second, third line treatments. Then maybe steroid, then maybe laser, lower down the list.
And the laser is one-time treatment and that's it?
Typically it's done in the office. You might need to have it over a couple of sessions, maybe 2 or 3 actual treatments, but then theoretically once you've had the laser, you may not need to repeat it again. So once it's done, if it's effective for you.
I think that there's a couple of reasons we use laser, and I think what Dr. Mruthyunjaya was referring to is, before we had injections, people would do light laser of the macula. When I started, it's called focal macular laser. We would do it for people who had diabetic macular edema. And now that is actually, I don't think anybody treats diabetes macular edema with laser anymore, because the laser itself can cause areas of blind spots and thinning of the macula. So I think the injections are good for that. Dr. Mruthyunjaya was showing some pictures of what the whole fundus, whole retina looks like in eyes that have diabetes, as well as some of these neovascular blood vessels that grow. And I think that's when we see areas where the circulation is not working in an eye that has treated melanoma, that's when we do the laser to kind of prevent more ischemia and to prevent new blood vessels from forming, not only in the retina, but also at the front. And if blood vessels form at the front of the eye, the person can get what's called neovascular glaucoma, so the pressure goes up, and that can start to get difficult to treat. And I think both of us kind of have a similar approach to sort of, we want to see that and treat it and prevent this abnormal blood vessel phenomenon.
So I think you have to be customizable to your situation. Yes, sir.
A little while ago, you talked about how the collaboration is growing so intensively in this field, and that's really exciting. It is, after all these years. I wanted to put the question back on you. Board, Melody, Sue, Mike, Lauren, what do you think about all these people in the room that are on the other side of the wall, as physicians, as experts looking at us? What, do you have impressions or thoughts about this collaboration?
I'm going to start with this one. I think it's fantastic. So I think that what this community needs, and I think I'm seeing more of over the years, is a collaborative voice. It's a voice for the patients saying that we want things to advance. It's for patients saying we want options for things that we can do to take charge of our disease and our condition. I think it pushes and it inspires researchers to be able to come up and ask questions that have the greatest impact. You've all been actually great supporters of many research programs across the country through all of your various outreach efforts and fundraising and participating in studies and having blood drawn and being in clinical trials, which I think at the end of the day, if you did nothing else, that would be the most important message, is that if there is something that's out there that you are considering or you want to consider to participate in, we can't do any of this discovery stuff without the patients that are willing to be a part of that process. So, please keep doing what you're doing, and I think that all these organizations serve different but yet overlapping specific interests, and I think that they all need to flourish as we go forward, or else we are not going to go forward.
I just want to add also that it's because of organizations like this that doctors are influenced. And I'm going to go back 6 years ago. It was, many of you know Sarah Seelig, who has founded Cure OM at the Melanoma Research Foundation. And because she was so engaged in the patient community, and what you need to do is get on the websites, meet other people, learn as much as you can, voice your dissatisfaction, and make noise about it. Because what happened was a whole bunch of us got together in 2013 at Sloan Kettering, and Sarah was there. She said, these are the two issues that patients are upset about. Number one, nobody has a standard protocol for liver screening. And number two, biopsy is available, but most centers don't do it. So we have to talk about how we're going to all change to make this happen. So you got all these people in the room, very stubborn, very brilliant, very intelligent, experienced physicians together. And we basically spent a day going back and forth, arguing, all these things came out. But at the very end of the day, after everybody aired themselves and said, well, I'm right and you're wrong, at the end, we put some action items together. Everybody agreed that if they didn't do biopsy, they would at least tell patients that this is an option, and because I'm not comfortable, I'm going to have you see this person. We had people actually do that. And before that meeting, no one would ever do that. I mean, the ocular oncologists are, they're very sort of set in their ways, but they can't be. And it's because of patients making noise about it. And the only way you can make noise about it is to read, learn, understand as much as you can, and you can influence your doctors. I mean, at the end of the day, we're really here to serve what people need. And I think that organizations like this just make that possible. So I would encourage you to keep doing this and think about what things that you're not satisfied with, what would you wish, and things will change. And I think it's because of patients that we've actually changed a lot of what we do. And doctors cannot work in isolation because it's hard. We can sort of appreciate something through our patients, but patients have to say, I don't like my doctor doing this. This really bugs me. And you gotta be open about it, because it's possible that we can change.
Well, that's why I asked you the bias question, because when I go home, I'm going to go talk to Carol and Sarah and Herman and tell them that they have to introduce patients to this organization. They have to. And they have to introduce them to Castle and to the other genetic screening companies. They have to provide those options and not just go with one singular genetic test. Period.
It's tough, but you can do it.
I'm going to go have that on
There's nothing to lose. There's no
What's to
way,
lose?
people do things. I mean, starting this field, some doctors, we would have these conversations, and I remember talking to one colleague, and he said, I don't do biopsies because that would really offend Dr. So-and-so. And I'm like, who cares? Who cares about old Dr. So-and-so? You just have to do what you feel is right, and you got to listen to your patients, and you got to really open yourself to that. Otherwise, you're just going to stay in this old-fashioned way of treating, and doctors can't be that way.
I have one thing to say. First off, I thank you for the treatment you gave this young lady and for everything that's going on. Keep up the good work.
You're very welcome. It's an honor.
Since we have the two of you together, do you see that the occurrence of OM is holding steady, or is it increasing, decreasing, just overall?
So we just looked at this and published a paper on it. So it looks like now when we look at the National Cancer Registries, which is the SEER database, now over the past 20 years, the incidence of OM is really holding steady. Conjunctival melanoma seems to be going up a little bit, but that's a small percentage of the overall number. But the overall incidence seems to be the same.
I've heard between 1,500 and 2,000. What's the
So
current number?
so yeah, it's about 5 to 6 patients per million in the U.S., which is about 2,400 new cases is the estimated number per year, new cases in the U.S.
Is there a worldwide or
Good
outside the
question.
U.S.
No.
number?
So there's not an accurate worldwide number for it. So we've actually looked at that to see if we can figure out what the true number is around the world. In most countries, most European and Northern European countries, the incidence rate is around what it is in the U.S. Some of the very high Scandinavian countries, it's maybe it's up to 7 to 8 per million, but a small population. I think Iceland is like 8 per million or something. But in other parts of the world, it's rare. Like if you go to India or Africa, there's just a handful of melanoma patients per the population, and then again, it's just sheer numbers that kind of create it. So we don't have that answer. I'll also put a plug into some of the collaborative work that's going on now for patients. So the Melanoma Research Foundation is working to have a patient-centered registry, which when it comes out, you all need to think about being a part of it. So basically, it's again listening to patients. They want to be able to know, like who's in this community with them. What's available in terms of clinical studies and screening, and you wouldn't know that I would qualify for a clinical trial if I wasn't collected somewhere in a repository of data, so that someone could say, oh, you might qualify for this, or you should know about it. What this is going to differ is that it's not just me as the doctor putting your name into my little logbook and following it forward. It's going to be a sponsored data set that everyone can put in. And it's patient-directed, which is a new initiative in cancer treatment where patients then can put in their own information into that data set voluntarily, talking about their family histories and other diseases in their family that kind of go with it, and that becomes a much more robust data set. The reason why it's helpful is that when companies then have a new wonder drug that they want to test, if they know that there are 10,000 patients with ocular melanoma that might fit their criteria for entry, they're much more willing to invest the millions of dollars it takes for discovery clinical trials than if they just assume, oh, this center has 100 patients and that center has 50 patients. This is going to be very powerful, and that information will come out. We'll make sure that we collaborate with the organization to get it out to you all, but these are just some examples of the efforts that will require patients and the doctors and the researchers to come together, but it's happening.
I sent you an email a while ago, and it was an article that came out in one of these support groups, and it was, and you'll remember, military people having this increase in ocular melanoma, and I tried hard to find the research for that, and so I wanted to bring it up because we talked about peer review. There's so many things that I've seen in these support groups that are coming out that there's no foundation, there's no basis, it's not scientifically driven.
Russian bots.
Yes. So I just wanted to say that out loud because I hate for someone to start eating dog food because it decreases ocular melanoma, which some dog treat was mentioned out there too. So
Dr. Google's a tough doctor sometimes. So I think you made the point earlier, sir, that there are good websites now, good organizations that have high quality data that they post, like NCCN. I think this organization does a good job with the data that's available. Work with your doctor and really push for data for questions that you have. I think sometimes just hearing people's experience is, you should take that as such. It's an experience of one. But if you're looking for kind of data-driven, I think the quality of the data and where it comes from, I think is important.
Yes. The other thing is you said we're going to start to have a center where all these people are going to be, hopefully signing up.
Yeah.
Will they also ask for background where people are coming from? I'm half Icelandic.
Yeah, so I think that's part of the data set is to collect as much of this information, and I think what's going to happen is that it will evolve, right? So once, so let's say the Icelandic feature is the most important risk factor that someone discovers. If you're in the data set, they can probe you back and say, hey, can you update your stuff? If you're Icelandic, please, click the link here and update it. So I think that this is, the potential is that this is going to be a growing, data collection, not just one-time full survey and you're done. And it's patient, directed. So that means you have to want to put that information in, but I hope you do.
What about collaborating with 23andMe?
Have you had patients that have done 23andMe?
Yeah, I have a few, and I don't know if we have any, well, sure, we don't have any data that to even really comment, certainly in ocular melanoma. So I think just time will tell. I mean, I think everyone's getting these, and we may eventually get some data, but I know in ocular melanoma there really is, I really can't comment. We'll just have to wait and see.
Can I ask what's happened with the data from the cluster in Auburn? And I mean, you get the data, but then what happens with it? Because that seems like an anomaly.
No, I agree, and then that's been a topic of conversation. A lot of people have brought those articles, and from what we know, we have a colleague who is evaluating those individuals, and we haven't had any, I haven't heard any data yet about if there's some associated factors, but it is being looked at. But we don't know yet.
Yeah, they've collected the patient level data, and now they're looking at, now there's some funding that's come in, as you're aware, for both the Auburn and the North Carolina groups. So now it becomes a epidemiologic and kind of public health search to see if there's other factors, and then correlations. But all the patients are being followed very carefully. And,
Well, I was just wondering who's actually.
Yeah, right. So
are we going to hear about that the next time the news media goes, oh, we had a story, let's go find out.
Yeah, right. So
I
think it's trying to keep the story alive, which is
Yeah.
important too. So there are two different groups at each of those states that have a local team that are working with physicians, oncologists, and then there are others across the country that are contributing, as part of a coordination effort. So it's ongoing. It's not going to be. These answers will take time. I think that's the issue.
Just going back technical, because you mentioned earlier that before the plaque, they use a laser. So before doing plaque, it used to be laser, or they are still doing laser. What would be the reason to do laser and not plaque?
Okay. So just to clarify, so one of the treatments that people have used before has been using laser to burn the tumor, instead of trying to treat a small tumor with a radiation plaque. And I think the data has shown, though initially everyone was excited, that there is a not insignificant relapse rate, so it's about 25% chance of not stopping the tumor, but also the complication rate can be significant as well. So I think unless in very rare cases where the patient can't tolerate surgery, I think most don't use laser up front. But sometimes you can use laser secondarily after the radiation is done in certain cases to help with that. So laser is used, it's very infrequent as a primary treatment for melanoma.
One quick point to digress for a moment. You were getting into some statistical area. Is it a dominant factor, or is it equal in male and female OM?
Equal. Equal opportunity.
It's an equal opportunity killer.
Yeah.
Okay.
What about occurrence in family members?
Yeah, well, oftentimes when we take a family history, we find that we often may discover other types of cancers in the family tree. But it's uncommon to have ocular melanoma in a direct relative. And if there is, because sometimes there is concern about a possible genetically inherited mutation on a mutation of BAP1, which is a tumor suppressor gene. And there is now, it's a recognized heritable cancer entity with called BAP1 predisposition syndrome, where you can get sort of direct lineage family members with ocular melanoma, but it's exceedingly rare. But we do find that certainly there seems to be more cancer in an individual that has ocular melanoma, but not always. And there's also other specific types of cancer that may be associated with this BAP1 mutation, such as renal cell carcinoma, so kidney cancer, certain types of prostate cancer, and some lung cancer. So it's not common, and fortunately, the vast majority of people with ocular melanoma, they're not going to pass it on to their offspring. But occasionally we do see the hereditary form. It's very uncommon.
Hey, a really practical question I learned from one of my new colleagues last night. When you go for the Avastin injection, her center was using an iodine antiseptic for the topical cleansing, I guess, of the injection site. Can you talk about washing that out really quickly? She said it burns like hell. And apparently they weren't washing her out the first time.
So I think every center probably does, or each doctor does their injections slightly different.
Okay.
Anything from no lid speculum, no gloves, no mask, or to like everything's covered with drapes. I mean, even at our institution, everyone does it differently. But I think that it is true that the povidone iodine it burns if the eye is not anesthetized. So being very, very sparing with that. And when we first started these injections, we'd squirt the whole bottle over half the face, and that's because people were concerned. But now we realize that you probably just need a single drop just moments before the injection. We do eye washing, but I find that most of our patients don't need it.
Okay, great.
But,
Thanks.
yeah. We had a question back there. I want to make sure.
Thank you. Is there a risk for prolonged exposure to having silicone oil in your eye?
So the question is there risk to the silicone oil? So in our experience, I mean, the longest a person's ever, well, actually we have a few people that have just decided not to take it out, and it's been there for a while. And there really is, the one risk that is talked about is that sometimes the oil in certain preparations can emulsify, so you can see little crystals. And sometimes that can be problematic in the eye. We've seen that a couple of times, but the oil was planning to cut, we were going to remove it anyway. But in general, silicone oil is considered a very inert, substance that the eye tolerates very well. And certainly before this, silicone oil is routinely used for more complex retinal detachment repair. And in many of those eyes, the oil may not come out.
Okay, because I'm unfortunately in that category. I had the 1,000 in and emulsified. I'm at 5,000 now. I've had it changed 3 times. I'm looking at next year as well.
Do you need to still have it in?
Oh, I still have it in, yeah. For about 1.5 years now. And my retina surgeon has told me it's not coming out until my eye comes out. So I'm just like, what's going on here?
Yeah, because we usually take it out, and the people who we don't take it out, it's simply because we don't think it's going to help their vision.
Okay.
And
well, I'm blind right now, so I'm like, what am I doing for? Yeah.
Yeah, you might want to just ask about, what's the long-term plan.
Okay.
Yeah.
Thank you very much, everybody.